moment to get focused. Today we train with purpose. Session with Coach Joshua will start soon. with Coach Joshua will start soon. Session with Coach Joshua will start soon.
Hello, everybody. Welcome to Office Hours with Coach. I am your host, Coach Joshua. So good to be with everybody. Now, I know we have different audiences tonight. We have those who are in our community. You're in Zoom. We also have people joining from Facebook and on YouTube. So welcome, everybody. For those of you who are new to our world, we've never had the pleasure of meeting. Who am I? So I'm Joshua Crawford. I'm a certified flight paramedic, graduate trained. I'm now completing my doctorate to be an emergency physician. My journey in EMS has spanned over 2 decades. I was an EMT intermediate, a paramedic, level 2 instructor, level 3 instructor, a certified flight paramedic. Been an educator now for 2 decades. So I've had 2 decades of clinical and teaching experience. So in that time, I've helped lots of people be able to pass exams. Now, what are we doing tonight? Tonight's focus is for us to kind of systematically walk through the questions and teach you how to break down these National Registry style questions. So we have some people on Zoom. I'll be able to interact with those of you on Zoom. Obviously, for those of you on YouTube or Facebook, I'm sorry I can't actually see you, but if you'll just put your comments in, I want you to participate as much as possible, stay as engaged as possible. You'll be able to go back and watch this. For those in our community, this will be uploaded to your portal probably tomorrow, so inside of school. So here's what we're going to do. We're going to just jump right into it. Let me know if you're ready tonight. Let me know if you're actually ready. Give me a ready in the chat. For those of you, wherever you are, just put in the chat, say ready. Let me know that you're ready, because I'm ready. Let me know that you're okay. So we got some readies, got some thumbs up. For those of you on Zoom, what I encourage you to do is use the little reactions tab at the bottom of your screen so that you can do fire emojis, things like that. If we say something that's like an aha moment, here's what I want you to do. if at any point we say something and you're like, ooh, the light bulb just went off, what I want you to do is just type in the comment nugget. Like if I drop some kind of little nugget for you, I want you to just drop a nugget in the comment so that when we go back and look at it, we can kind of see where were those aha moments. All right. So now that we're ready, here's what we're going to do. The first name I happened to see was Teresa. Teresa, how are you doing tonight? Let's see. Can I pop you up in the box? Teresa, are you there? Hey,
I
how are you
am
doing?
here. Can you hear me?
I can. Can you hear me okay?
I
All
can.
right. So here's what we're going to do. Are you ready to jump into the first question with us?
Oh, well, let's try and
Okay, no
see.
problem. And no pressure at all. If you don't know something, that's okay, because that's why I'm here. And if I don't know it, we'll look it up. I'll just tell you I don't know it. We'll look it up. Chances are good that I should be okay though. All right, so we're going to take the very first question, and so let's just jump right into it and see kind of where we are. So hang on just a minute. Let me see if I can get us all on the screen at the same time. It looks like we're there. You've got my screen. If you guys will, let me know. Just say yes if you have my screen.
Yes, I do.
Okay, everybody's got the screen. So we're going to take this very first question. Now, you're actually one of our students in the cohort. So, depending on how far you've gotten through the 21-day game plan already, you may know this or you should know this already in terms of our 5-star medic method. However, we've got people tonight who are joining us. This is their very first time. They're joining from somewhere in the country or around the world. This is their very first time. So, some things I'll have to repeat just for the benefit of everybody. But we're going to take this very first question. So, you ready? Let's get started.
Let's go.
All right. So this question now, and by the way, let's just kind of recap something, just so that everybody's on the same page. Here's what I'm going to do. I'm just going to add a sheet really quickly. Uh, Let me just add a page so that I can write. Now, let's just quickly go over this for everybody. I'll take it off. You stay where you are, Teresa. We're going to come back to you. You're going to
Okay.
take that first question. But let me just go to me for just a moment. For the benefit of everybody, I teach something called the 5-star medic method, okay? So here's a star, and we have 5 points of the star. All right, let's move that down a little so you can see. By the way, I'm looking at multiple screens here. So if at any point you cannot see something that I'm doing on the camera, somebody just come off mute and let me know. All right, so here's the 5-star medic method. There are 5 points of the star. And so we've got points 1, 2, 3, 4, 5. The very first point of the star is there a safety concern? Okay. So when you're doing National Registry style questions, our very first question to ask is there a safety concern? Or what is the safest thing that I could do right now? That trumps everything else. It beats patient care. If there's a safety concern with the scene, or we need some kind of BSI equipment or something else, we need additional resources. That's actually the number one priority, no matter how bad off the patient is. Number one is there a safety concern? Step number two, we're going to ask, is this patient sick or not sick? And the reason that's important is if they're not sick, the answer is probably we don't do something. Like we don't need to do something if they're not sick. In that case, what do we do then? Well, we're probably just going to support them. Maybe we're going to contact a friend. We're going to maybe arrange for some other social services, but we're not actually going to treat them if they're not sick. The third point of the star is stable or not stable. So we definitely want to be able to recognize unstable very quickly. Instability is something that we need to recognize right away. Now, what clues you in that a patient is sick? Some of the first signs that you're going to recognize are increased heart rate with symptoms. And the reason I stress it that way, it's not just increased heart rate, it's increased heart rate with symptoms. Because if you get up right now and you run outside, your heart rate is going up, but you don't need an ambulance because you're not actually having symptoms. So you have an increased heart rate, but no symptoms. So one of the first signs that we recognize is increased heart rate with symptoms, also increased respiratory rate with symptoms. Now, when it comes to how do we recognize that a patient is unstable, we're looking for signs of shock. Okay, so that's going to be maybe they have pale, cool, clammy, or pale, cool, diaphoretic skin. So changes in their skin. We're looking for things like altered mental status. We may have hypotension as a later sign. So any of these that are going on with the patient says, this patient is unstable. Now, why do you care? Because if they're sick, that means that we do something as opposed to not doing anything. If they're unstable, not only do we do it now. And the other thing is we need to initiate rapid transport. So sometimes that's the answer. Like, do something and initiate rapid transport. Point number 4 is, do we fix them or do we just support them? Okay. So, for instance, if they're sick, that means we fix something. If they're not sick, then we're just going to support them. Now, all fixes, if you've been around me for 20 minutes, you've heard me say this. But for those of you who have not, all fixes in the whole human body, everything we do comes down to, hang on. All right, let's see here. Let me just change my screen so you can see a little better. Hang on just a moment. Don't go anywhere. All right, bear with me just a moment so I can scroll up. Okay, now, all fixes come down to we either fix an oxygenation problem, a ventilation problem, or a perfusion problem. I don't care what scenario it is. Last week in our live community, I actually did this thing where I went through about the top 50 calls that we have in EMS. And I broke down every type of call as an oxygenation problem, a ventilation problem, or a perfusion problem. See, most of you learned airway, breathing, circulation. That I find helps. It doesn't help you as much, and it actually causes you to miss more questions than you get correctly. All right. So all fixes talk back to me. All fixes come down to oxygenation, ventilation, or perfusion. Okay, Christopher, you asked, can I make my screen bigger? Once we go to the actual questions, I think you'll be able to see it. If not, let me know, though. So all fixes come down to one of 3 things. We're either going to fix oxygenation, ventilation, or perfusion. And then finally, the 5th point of the star is there a time-sensitive, anything that's time-sensitive? That's going to be like major trauma, complicated childbirth, seizures, problems with the airway, a STEMI, a stroke, things like that. Those are time-sensitive. So let's recap that. The 5-star medic method, these are the 5 questions that we got to get everything down to. Is there a safety concern? If so, that's the answer. We got to fix the safety concern first. Then we figure out, is this patient sick? Some things we look out for are increased heart rate with symptoms, increased respiratory rate with symptoms. But if they're sick, we got to do something. Okay, now we got to figure out, are they stable or not stable? If they're unstable, not only do we do something, but we got to do it now, and we got to do rapid transport. Then we figure out, okay, well, what do we need to fix? Well, all fixes, it's either an oxygenation problem, a ventilation problem, or a perfusion problem. Sometimes it's 2 of the 3. Sometimes it's all 3. But we've got to figure out, okay, what's the one thing that's going to kill this patient in the next minute if I don't do it? And then once I take care of that, what's the next thing that would kill this patient in minute number 2 if I don't do it? Okay. And then anything that's time sensitive, that means that we got to get them to an appropriate facility where somebody else with more training, more experience, more resources can take care of that situation better than us. Okay. Any questions so far? And type in the chat for me. I'll be monitoring the chat, but sometimes I can't. Sometimes it's going too fast and I can't see it all. So if you have a question, just let me know. But everybody good so far? Okay. Now we're going to use that. Now, the next thing I want you to know is how we take a test, okay? There are 5 steps to taking a test. How many steps? Type it in the chat. How many steps to taking a test? All right, 5. Angela says 5. Good. Okay, so step number 1 is to read the actual question. And the reason that's so important is because sometimes they make this scenario so long, but you don't need anything in the scenario. As we go through questions tonight, I'm going to show you like what's important, what's not important. Some things in questions, like it's just extra information that it's just there to confuse you or distract you. We could answer the question without that at all. So we're going to figure out first, what is the question? Then we're going to figure out, is this a 1-step question or is this a 2-step question? Now, what's the difference? A 1-step question is where you make 1 step from reading the question to the answer. You only make 1 step. So in a 1-step question, an example of that is like, what's the class of drug of albuterol? What's the class for oxygen? What's the mechanism of nitro? No matter what story they give me, it's not going to change that answer. That answer is always going to be the same. The mechanism of action for nitro is we take nitro, gets converted to nitric oxide, enhances cyclic GMP, or activates guanylate cyclase and enhances cyclic GMP, causes veno and vasodilation. They could give me 100 different stories, but that answer is always going to be the same. That's a 1-step question where I don't need a story. A two-step question is where I do need a story, so I got to actually read the story. So that's going to be step number 3, is to read the story, but we don't read it like a book. And we also don't read it like an auctioneer. Oh, we got a 54-year-old. We don't read like that because we're going to miss all the clues. So we're just going to carefully analyze a few words at a time, picking out those clues. Step number 4 is sometimes we got so lost in the story, we forgot what the question was. So we're going to just read the question again. Okay. And then finally, we're going to let our brain come up with the answer. All right. And then whatever our brain said is the answer, we're going to trust that that is the answer. Now, let's put all this into practice. So we're going to go back to, who did I have? I had Teresa. Teresa, you ready?
Yes,
all right,
sir.
let's go. So we're going to apply this. And hang on, let me just change out my view again for everybody. And let's see. Okay, here, let's see. Can you see that okay?
I can.
Okay, so here's what we're going to do. We're going to start with where would you start when you're reading this? Where do you start?
At the question.
All right, so where's the actual question in all this?
Using the adult rule of nines, what is the estimated percentage of partial thickness burn?
Check you out. That's
area?
the actual question. So this question, no matter what they tell us in this story, the actual question is, what is the estimated percentage? So we need a number. Okay. Now, is this going to be a 1-step or 2? Can I just answer the question just based on that alone?
No, I think it's going to be a 2-step.
Yeah, this is a 2-step because I got to figure out how badly is this person burned. Okay. But yes, I don't need everything in this story. I only need enough information to tell me the burn percentage. That's it. So let's go through this one. And I want you to read out loud so everybody can hear you.
Okay. What did I do with my glasses? Okay, I think I can see. A 32-year-old male.
All right. And I'm going to highlight what's actually really important for you to know. Keep going.
Okay. 32-year-old male was pulled from a house fire. He is awake, coughing, and has partial thickness burns to his entire anterior chest, entire anterior abdomen, and the entire front of his right arm. He also has
Stop right there. Stop right there.
Okay.
Now watch this. I don't need anything else in this question because this actual question just wants me to calculate a percentage. These vitals don't matter because those vitals are not going to change the answer to this question at all, right? All I needed was enough information to pull out enough clues to figure out this percentage. So in this case, we're going to use our rule of nines. Is this an adult or kid?
Adult.
All right, this is a 32-year-old, so it's an adult. Why do I need to know that? Because the rule of nines is different when you're talking about adult versus pediatric patients. So let's go over the adult rule of nines. All right, so here's your patient. All right, we got a head. We got here. Let's clean this up a little because Teresa's already making faces about my drawing. I know it. All right, so here's this patient, right? And it doesn't have to look good, but let's figure this out. Okay, so here's your patient. This patient has partial thickness burns. Why did I highlight that? Because when we're calculating the rule of nines, what matters is partial thickness and full thickness burns, not so much superficial. So you may have learned it as first, second, third, or first, second, third, fourth degree, but we kind of ignore superficial burns when it comes to like fluid resuscitation. So we're specifically looking for burns that are partial thickness and full thickness, okay? So he has partial thickness burns to his entire anterior chest. Now the chest is just, all right, so this whole thing here, that's the thorax, but we have a chest and we have an abdomen, okay? Now this whole thing is 18%, but the entire chest, that's 9%. Okay, the entire abdomen, the anterior portion of the abdomen is what percentage?
9.
That's also 9%. So this whole thing is going to be 18%. Now he has also partial thickness burns to the entire front of his right arm. So the anterior part of his right arm. So over here on his right arm, we're going to say this is the front part. How much is the entire arm for an adult or kid?
9. It's 9.
The entire arm, front to back, is 9%. But if they're only saying burns to the front, that's half of it. So what's that going to be?
That's going to be
4.5.
4.
Yeah, so we got 4.5%. Okay. So now when we add all this up together, what's our percentage? What's our total? What's our total percent burn surface area? So we've
22.
okay. So in this case, we got 22, 22 and a half. So yeah, in that case, in fact, this was like an EMT level question that could be found on an exam for EMT, AMT, or a paramedic. Okay. This is just a basic question where it's just you knowing some kind of basic information. Okay. So good. How about you do about 5 in a row? You ready?
Okay.
Okay. So since you're ready, since you're so good with calculating burn percentages, let's go to question number 2. All right. So this is more of a paramedic level question or an advanced CMT question. So let's keep going. Now, this is a separate
Um,
question. So start with a question,
so
Teresa.
let's see.
Starts right here.
Using the Parkland formula, how many lactated ringers should be infused per hour over the next 6 hours?
Okay. So the question needs to be so much per hour over the next 6 hours. That's what we're trying to figure out. This is going to be a 2-step question. We need a story here. And they want us to use the Parkland formula versus the consensus or the Brook formula. Okay. We're going to go with Parkland. First of all, what is the Parkland formula?
Yeah, I don't know.
All right, so we're going to get to that. Hold that thought. So let's just go to the question then.
Okay.
All right, so let's start with the question. For the rest of you, type it in
100
the chat. Tell me the Parkland formula real quick. But Teresa, you keep
Oh,
going with the questions. Let's start here.
okay. A 154-pound adult has partial thickness and full thickness burns to his entire anterior torso and the entire left arm.
Okay, hold on.
The
So
burn
entire
Okay.
anterior torso and entire left arm. Okay.
The burn occurred 2 hours ago.
Okay. That's probably important. Okay, keep going.
Mhm. Using the formula, how much lactated ringers should be infused per hour over the next 6 hours?
All right. So Maris says that it's 4. Okay, that is right. So this is the Parkland formula for everybody. So Parkland. Okay. Now, why do we care? It's because burn patients, what are burn patients? What are the 2 biggest killers of burn patients? What are the 2 killers of burn patients?
Fluid loss.
Okay, so we're going to call that dehydration. And that dehydration that gets worse can lead to what kind of shock? What category of shock would it be for fluid loss? I got it, Amanda. No problem. Okay, so that's going to be hypovolemic. So hypo is not enough. Volemic is volume. So when you lose in volume, that's hypovolemic shock. So number 1 is going to be dehydration that can cause hypovolemic shock. Number 2 is going to be infection. Okay. See, that infection, what can that lead to? The infection can ultimately result in septic shock. So notice how both killers ultimately result in some type of shock. Now, all types of shock, is it primarily an oxygenation, a ventilation, or a perfusion problem if it's shock? What kind of problem is this? Perfusion. Okay, shock is the definition, or the definition of shock is inadequate or hypoperfusion. So, of course, it's a perfusion problem. That's why we have to be so aggressive with our fluid resuscitation in all burn patients. Same for septic patients. Okay, now the Parkland formula says that we take the number 4. This is just a calculated value. It's always going to be 4. We take just the number 4. We multiply that times the patient's weight in kilograms. Okay, patient's weight in kilograms, and we times that by the percent burn surface area. Okay, so it's 4 times weight in kilograms times the burn percentage. Now, in this case, did they give us our weight in kilograms?
No, they gave it to us in pounds.
All right, so what's our conversion from pounds to kilograms? All right, so to go from pounds to kilograms, we take the weight in pounds divided by 2.2. So if we take, so for everybody, just do that for me on your calculator. Go 154 divided by 2.2. And what are you going to get? you're going to get 70 kilograms, okay? So 70 kilograms. Now, so we got the 4 part because that's just a constant, and we got the weight because they gave us the weight. We just had to convert it from pounds to kilograms. Now, the only thing left to figure out is the burn percentage. So let's figure this out. So what is this patient's burn percentage? This is an adult or a kid?
Adult.
This is an adult. Okay, so let's figure out this patient's burn. Okay, so where's his burn? He has an entire anterior torso. So torso, that's going to be consisting of the chest and the abdomen. So that whole thing is how much?
18%.
That's going to be 18%. And the entire left arm, not just the anterior, not just the posterior, but the whole thing. So what's the whole left arm going to be?
Another 9%.
That's going to be 9. So when we add those two together, what's our percent burn surface area? 18 and 9, that's going to be 27. So here's what I want everybody to do. Take 4 times 70 times 27, and what do you get?
70 times 27. 7,560.
Okay, so you gave me, so whatever number you get, that is the amount of fluids they get in the entire 24 hours. Now,
they want to know
when does the clock
next
start? It's from the time of the burn, not when you show up. Okay. So in this case, this patient has already been burning for 2 hours.
2 hours.
Okay. So immediately we need to be stopping the burning process. Okay. Some of you have the answer already, but what we're going to do is whatever answer you get. So 4 times 70 times 27, I think you said 7560. Is that what you said?
Yes.
Okay, that is the amount. So this entire 7560 is the amount over 24 hours. Okay, but what we have to do is we have to take that number and we have to cut it in half. So if I take 7560 and I cut it in half, we're going to give half of it in the first 8 hours, the other half over the next 16 hours. So what's half of 7560?
3780.
Okay, so that means he gets 3780 for the first 8 hours and then another 3780 for the next 16 hours. In this case, this burn happened when?
2 hours ago.
2 hours ago. So so how many hours do we have left of the 8? If 2 hours have already been used up, and we didn't give fluids, we got to make up for the lost time, so to speak. We got to make up for the lost fluids. Because in the 8 hours from the time of the burn, he has to get that amount of fluids. Except we've already lost 2 hours. So what that means is now this 3780, instead of it being given over 8 hours, it now has to be given over 6 hours. So we're going to take this 3780 and divide by 6. And what do we get?
630.
Okay.
B.
And just like that, that's our answer. Now, obviously, it took me a little longer to explain it than it's going to take you on a test, but that's how you would approach like one of those burn kind of questions. By the way, what is our preferred fluid in a burn situation?
Lactated Ringer's.
All right. And in fact, that's what they wanted us to give. Now, why is Ringer's the preferred fluid in major trauma, burns, and sepsis compared to normal saline? Why is Ringer's the preferred solution here?
It prevents.
All right, so let me help you out. So in normal saline, it's made up of sodium and chloride. What happens is this chloride leads to acidosis. And for those of you who were with me last week, I went through a whole thing about the acidosis. But the acidosis is also going to lead to vasodilation, and vasodilation is going to lead to shock. Remember, the 2 biggest killers in burns are dehydration, which can lead to hypovolemic shock, and infection, which can lead to septic shock. So you don't want to, they already have 2 things that can give them shock. You don't want to give them fluids that's also going to worsen the shock. Does that make sense? So Ringer's, because it doesn't have chloride, instead Ringer's has sodium, potassium, calcium, and lactate, instead of chloride. Because it doesn't have the chloride, it's less likely to cause acidosis, less likely to worsen the shock. Does that make sense? All right, you're on a roll, Teresa. Let's bring it. All right, don't embarrass us now. Let's keep it moving. Okay, you're doing good. You're doing well. All right, let's take this next one. Let's take question number 3.
Let's see.
Which it starts. So here's your actual question.
Mm-hmm.
All right, read that.
Which I'm having a hard
That's
time
okay.
saying
Pathophysiologic.
and saying it. Which pathophysiologic, however you say it, process best explains the
Deterioration. Okay. So what they're
Okay.
saying here is this patient is getting worse. What's the problem? Is this going to be a 1-step or 2-step question?
It's going to be a 2-step.
Yeah, this is 2-step. I need a story because I don't even know what's going on. So this is a 2-step. Let's go with the story. In fact, let's just blow this up for you so you're not struggling there.
Well, I found my glasses.
Okay. Let's go.
A 68-year-old female with pneumonia is confused, febrile, and hypotensive. BP is 82/48.
Okay, let's slow down a little. As we're reading, we want to remember we don't read like an auctioneer. We got to pick out clues along the way. So already, let's start off with this. We got a 68-year-old female. Why do I care about that? Because once this patient is over 60, we're going to classify her as elderly. Elderly patients have more comorbidities. They got a lot more medical problems, okay? They tend to be more sick. So I have an elderly female. What else is special about elderly female? They are in that group of atypical chest pain where they may be having a STEMI, they're having a heart attack, but they may not have chest pain at all. So elderly female, diabetic especially. I've got 2 of the 3 so far. I have elderly and female. That's enough to be suspicious for like acute coronary syndrome. Okay. Now, this patient's having pneumonia. All right. So currently or recently had pneumonia. Now we have confusion. So confusion, we're going to call that altered mental status. Altered mental status, does that make this patient sick or not sick?
Sick.
All right. This is a sick patient. That means I do something. Now, if this patient is having altered mental status, is this patient more likely to be stable or unstable?
Unstable.
This probably is an unstable patient. So this patient is sick and unstable. I have that from the first line of the sentence. Okay, this patient is febrile. What does that mean?
Fever. The fever.
Yeah, she's having a fever and she's hypotensive. How hypotensive is she? Well, this blood pressure is significantly hypotensive, okay? So she's hypotensive, and how do we call this?
What did you say?
How do we call this?
Her heart rate.
So what word do we use to describe this heart rate? Say tachycardic.
Tachycardic.
Yeah, she's tachycardic. Good job. Okay. What word do we use to describe this respiratory rate? Type it in the chat, everybody. Everybody participate with me. Okay. Tachypneic. She's tachycardic and tachypneic. Remember I said you have increased heart rate with symptoms, increased respiratory rate with symptoms. That points to sick. Okay. She's hypoxic. She's at the cusp of hypoxia. So far, we've got hypotension. That's a perfusion problem. Tachycardia, that's kind of a perfusion problem. This respiratory rate, that can point to oxygenation or ventilation. This hypoxia kind of points to an oxygenation issue. Her skin is hot, but mottled, okay? Now, this mottle, that's a clue. This mottled skin. Now, during transport, you notice?
Bleeding from her IV site.
Okay. And keep going.
Whatever that word is.
Petechiae?
On her chest. So it's
all right, what does that even mean? Petechiae on the chest.
Is it like blood?
Okay. It's these little like purple little pinpoint kind of dots. Now, when it's when it's little dots like that, that's petechiae. When they're larger patches, we'd call that purpura. Okay. But this is petechiae, so it's the little dots. Okay. So she's got petechiae on her chest, and then what else?
Oozing from her gums.
Okay, oozing from the gums. All right. Now, so let's go through this. What do you think is going on with this patient? This patient who had pneumonia, who's confused, febrile, hypotensive, what is this painting a picture of?
She's probably septic.
There you go, sepsis. Okay, so we have septic. Not only is she septic, she's actually in septic shock. Okay, now where are clues for shock? Well, remember shock, we're looking for things like pale, cool, clammy, pale, cool, diaphoretic skin, altered mental status, hypotension, delayed cap refill. She's got a lot of this. So she's not only septic, but she has septic shock. Okay. What's another complication of septic shock that explains all these symptoms or signs like petechiae, bleeding from her gums, things like that? Why is she bleeding? All right, so what we're going to do is let's say we don't know if our brain didn't just immediately come up with the answer, we're going to kind of use our process. We're going to use our framework and our system. Let's come up with the answer. Now, what I recommend is that you start with the bottom of the answer choices. And the reason for that, we're going to start with the bottom and work our way toward the top. The reason for that is more often than not, the distractors kind of come from the top. So let's start with this one. Let's go with, we said that this is primarily a perfusion problem. All right, let's keep that in mind. Now, let's start with letter D. And let's read this one.
Autoimmune destruction of red blood cells causing hypoxia.
Okay. And so would you expect that to just happen like right now?
No.
If it's an autoimmune condition, this is probably a chronic condition that is going to happen gradually over time. And in this case, that could explain the hypoxia, but the hypoxia is more of an oxygenation problem, and she has more of a perfusion problem. So just because this has hypoxia in it, even if I don't know the rest of this, even if I don't know like what situation they're describing here, and it's not important that you do know, it could be some kind of hemolytic anemia or something like that. We don't know. We don't have to know what the name of it is, but because it's talking about hypoxia and that's an oxygenation issue versus a perfusion issue, I'm going to eliminate it just with that. Let's go to the next one.
Acute coronary plaque rupture causing cardiogenic shock.
Okay. Now, septic shock, is septic shock a type of cardiogenic shock? Septic shock is what type of shock? Okay, that's okay. And all right, so you may not have gotten this far, but septic shock is a type of distributive shock. Remember, all distributive shocks affect your autonomic nervous system. Oh, let's do that in a different color. Autonomic nervous system.
Okay.
The A stands for anaphylactic. The N is neurogenic. And the S is septic. So anaphylactic shock, neurogenic shock, and septic shock are all distributive types of shock and not so much cardiogenic. So there again, I don't have to know all of this, but this is talking about cardiogenic shock. And I said, my brain said septic shock. That's the wrong type of shock. That's why I'm going to eliminate it. Let's go to the next one.
Isolated vasodilation from histamine release.
Okay. Now, does that point to something? Now, vasodilation is a form of like in distributive shock, you do have massive vasodilation. But which of these types of distributive shock is primarily a histamine release problem?
Anaphylactic.
That's going to primarily be anaphylactic shock. And we said this is septic shock. So there again, I'm just going to eliminate it because it's got the wrong detail there. Boom. Just like that, even if I didn't know the rest of this, I've eliminated to get to the right answer. And so I'm left with A. So what they're talking about, widespread clotting activation consuming platelets and clotting factors. That's the exact situation that happens in DIC, disseminated intravascular coagulopathy. Now, what is that? It's where it's associated with things like, all right, so who gets DIC? Lots of patients can have it. The three big things I want you to think of is somebody who's bitten by a snake. So some kind of snake bite, pregnancy, and sepsis. In this case, we have the septic patient Now, what is it? It's where your body starts making clots. So you get this widespread clotting. But because you're making all these clots, you're also, in order to make clots, you have to have platelets and you have to have clotting factors. So you're going to, in order to make more clots, you're going to be using more platelets and using more clotting factors. Well, it's kind of like, think of it like a bank account. If you've got a bank account of platelets and clotting factors, if you start using them up, now you don't have as many left. And when you don't have as many left, now you can't make more clots. So you first start making clots, but then you run out of the stuff to make them and you can't make any more. And so now it's going to lead to bleeding. So first they have kind of clotting and then later they have bleeding. So they've got like two bad extremes happening at the same time all over their body. So the reason she's bleeding from her IV site is now her body can't make, we don't have any more clotting factors or platelets to make more clots. Does that make sense?
Mm-hmm.
Okay, so that's DIC. The three big things that I want you to know for DIC: snake bites, pregnancy, sepsis. All right, let's do here. Let's do one more with you, Teresa, and then we'll swap you out.
Okie doke. Your partner is pregnant. So the question is, what should you do first?
Okay, one step or two step?
It's going to be a two-step.
All right, this is a two-step question. Let's go.
You arrive for a 58-year-old male found unresponsive on the bathroom floor.
All right, stop right there. Anytime I have a patient who's unresponsive, what's the first thing I do next?
Check a pulse.
We're going to check a pulse because we got to figure out right away, is this patient in cardiac arrest or not? Okay, if they're in cardiac arrest, then we're going to start CPR. If they're not in cardiac arrest, meaning they do have a pulse, then we're going to start rescue breathing if they're not breathing. So the first thing is check for a pulse. If unresponsive, remember the order changes from ABC to CAB. Okay, now, so this patient is unresponsive. So immediately I'm looking for, check for a pulse. Keep reading. He
is on the bathroom floor. He is not breathing normal. And
not
has
breathing
no pulse.
normally. Okay, so we're going to say that's like agonal breathing or gasping kind of breathing. Okay, and
he has no pulse.
All right, stop right there. What do I know about this patient? Because I was looking for pulse. They gave me the information. He has no pulse. That puts him in what?
Cardiac arrest.
All right, cardiac arrest. Is that an oxygenation, ventilation, or a perfusion problem?
Perfusion.
It's primarily a perfusion problem. What are the top three priorities in cardiac arrest? Number one, it's going to be high quality CPR, high quality CPR, not rinky dink CPR, high quality. The next is going to be early defibrillation. So we got to put the pads on. Well, first we got to turn on the AED or the monitor, put the pads on, allow it to analyze, and then shock when it tells us to, or when we interpret that we need to. So priority number one is early CPR, priority or high quality CPR. Priority number two is early defibrillation. Priority number three is IV-IO access for epi. Okay? Now, what we got to know here is CPR, though, consists of two things. CPR is chest compressions. It's also ventilation. So sometimes they'll break these up as like, if you had to pick three of what three things are you going to do? If they give you compressions and ventilations, well, that counts as two things. If they don't break it up like that, then we'd go CPR, then defibrillation, then epi. Remember, if they break these up, this is one, this is two, this is three. If they don't break it up, this is one, this is two, this is three. Okay? But just know these are the top three priorities in cardiac arrest. So based on that, find me an answer. What should I do first? Find me an answer.
Begin high quality chest compressions.
Right, because that's kind of the starting point for cardiac arrest. It's immediate high quality CPR. Okay. Now, what about when the AED comes? When should you use the AED?
After the first 2 minutes of CPR.
Okay. And we ideally want to use it as quickly as possible. I mean, if we can go ahead and get it deployed even faster, then we will do that because the patient's chance of survival goes down about 10% per minute. Okay. Now we're going to do, good job, Teresa. How did you feel about that?
Yeah, it's
good. Okay. Jalen, you ready?
Yeah.
All right, Jalen, you're up, man. Let's go.
Yes. All right.
And by the way, for those
What?
of you on
Oh,
Facebook or YouTube, make sure you type it in the comments. Remember, if you have an aha moment, just type nugget in the chat, okay? Obviously, for those of you on Zoom, I'm able to see you and interact with you a little more. But for everybody, I want you participating. So, Jalen, let's take this next one.
okay. All right. So, what is the best next action?
Okay. One step or two step?
This is a two-step.
All right, let's give me a story.
Okay. 24-year-old female ate shrimp and now has diffuse hives, facial swelling, wheezing, and dizziness.
Okay. All right.
To
Is
me,
there
this
safety concerns so far?
no, not so far.
Not yet, but we got to watch out for these shrimp. They may jump up and bite us. We're always looking out for
Correct.
them. Now we're going to figure out, is this patient sick or not sick?
This patient is
This
sick.
patient's sick. We probably need to do something. Okay. Then we got to figure out, is this patient stable or unstable, to figure out, do we do it like right now in rapid transport, or do we have a little more time? All right. Blood pressure is
86/50.
okay. How would I describe
Heart
this?
hypotensive.
Ooh, patient's hypotensive. Now, hypotensive, does that make them stable or unstable?
Unstable.
All right, so now I have sick and unstable so far. That's a different situation than sick and stable. All right, I have a patient who's hypotensive. Tell me about this heart rate.
It's elevated.
Okay, not just elevated. We call that tachycardic. Okay, so we have tachycardic patient who's hypotensive, tachypnic, and kind of on the low end of, that's below normal, but it's bordering hypoxia. She's anxious and states, my throat feels tight. What's making her throat feel tight like that?
The swelling.
Okay, she's got the swelling. Now, what's causing all the swelling? So the result is like this. So the result is hives, facial swelling. We've got wheezing. But what's making all this stuff happen? Give me the patho of anaphylaxis.
Oh, okay. You want the beginning, like the sensitization?
Sensitization. Let's start there, my man. Since you want to show out.
All right. No, I'm not trying to show. Okay.
Let's go.
All right. So first, when your body gets introduced to the antigen, your body.
Okay. And in this case, we're going to call it an allergen. So your body gets exposed to some kind of allergen. Keep going.
Then your body becomes sensitized to it. So then you have your IgE.
Okay. So your body starts making antibodies to be able to fight this. And the main antibody that it's going to make is the one called immunoglobulin E, IgE. Okay. There are 5 classes of antibodies: IgG, AMED. So game with a D on it. So let me put you on game. But the one for allergens is IgE. Okay. Now, that's what happens the first time. And who makes these antibodies? That's going to come from B cells.
B cell.
Okay. Now, your second exposure, what happens?
The IgE makes a cross-link.
Ooh, check you out, my man. All right. So we got a whole bunch of IgEs that come together. That's called IgE cross-linking. Good. What happens next?
Then we have the mast cell that creates histamine and leukotriene.
Nice. Okay. So I love it. Okay. So we have histamine release. We also have leukotriene release. And what happens is the cell membrane gets damaged of these mast cells. And now when the membrane gets damaged, it's like the border is not secure. So stuff can go in and out. And what happens is this histamine leaks out and starts going over in the skin, and it causes hives, itching, rash, things like that. Also, when this histamine and leukotrienes get out, for instance, in the airway, they're going to cause bronchoconstriction. In the capillaries, they're going to cause increased capillary permeability. That just means the capillaries start leaking out. In the arterioles, that's going to dilate the arterioles and cause vasodilation, and that's what's going to lead to the shock. So this patient has anaphylactic shock that was started off by histamine release due to this. So this cluster, let's go back over that again. You have this cluster of IgEs that came together, and they go over to the mast cell and say, hey, mast cell, you got to break up your party. You got to go home. The histamine and the leukotriene, they get upset, and then they start wreaking havoc everywhere. We get histamines and leukotrienes causing local reactions in the skin and causing more severe anaphylactic type reactions systemically. Okay. This is why we're going to use different medications. So let's talk about what happens. We have, remember, in the lungs, we're going to have bronchoconstriction. So in the lungs, we have bronchoconstriction. In the capillaries, we're going to have capillary leakage. So stuff is just going to start leaking out of these capillaries. In the arterioles, we're going to have vasodilation. Okay? This is why we're going to use different drugs to handle different things. What is our number one drug that we're going to use in anaphylaxis?
Epinephrine.
Our number one drug is going to be epi. Why? Because epi has three main effects. What are they?
Alpha 1, beta 1, and beta 2.
Okay, alpha 1, beta 2. I like it. This alpha 1 effect of the epi works right here. Alpha 1 causes vasoconstriction, so it's going to counteract all this vasodilation. Okay? The beta 1 effect, one of the side effects is it's going to increase cardiac output and it's going to increase heart rate. This patient's heart rate is already tachycardic. We're probably going to make it more tachycardic, but they'll at least be alive. So this is just a side effect. We don't want it to happen, but it's probably going to happen and we can't do anything about it, but we got to look for it. Okay? We got to be prepared to handle that. The next big effect is this beta 2 effect that causes bronchodilation. Because remember, we have all this bronchoconstriction. We're going to counteract it right here with this beta 2 effect. So because the epi is going to work right here, the epi is going to work right here, it's going to help with two big problems. That's why it's the first line drug, even over oxygen. It handles more problems, okay? So find me an answer for the first line drug that we're going to give for this patient.
C.
C, okay? Now, why is D not the right answer?
Because albuterol wouldn't be the first treatment.
Yeah, albuterol is going to work here, but it's only going to do one thing. Both the albuterol and the epi, both of them have a beta 2 effect. It's just the epi is going to do more to prevent this shock from getting worse. Okay? The albuterol is not going to help this shock part. Keep going. What were you saying?
I was going to say also, isn't this a perfusion problem?
It is. It's it is.
Primarily.
This is one of those examples where you have a lot of problems. This is actually where you have an oxygenation and a perfusion problem. It's just the perfusion problem is actually in this case, the airway closing is what would kill them first, even over the perfusion, because they at least have some perfusion, at least for now. They may not have much perfusion in 5 minutes. So in this case, what's going to kill them first is their airway closing. That could kill them in the next minute. But epi is still going to help with that, but it's also going to help restore the perfusion. Okay? Why is B wrong?
Because that's like delaying care.
Right. And definitely placing her supine is probably going to make it harder to breathe. She's already struggling. We don't want to make it worse. Okay? And why is A wrong?
That's not the first line of drug that we would give.
Oh. Is diphenhydramine a drug that we will use in the setting of an allergic reaction or anaphylaxis?
Yes.
Absolutely. How does diphenhydramine work? What's its job or what's its class?
It's called an antihistamine.
It's an antihistamine that's going to counteract all this histamine release. It's just a drug that we're going to use later. And then one of the other big things that's going to happen is we're going to end up with all this inflammation. And what's our drug that's going to kind of help counteract some of this inflammation?
Methylprednisolone.
Methylprednisolone, so solumedrol as a corticosteroid. Okay, good. So in this case, epi, first-line drug for anaphylaxis. All right, you want to do another one?
Of course.
Of course. Let's go. So this is an EMT level question. Big bad paramedic ought to be able to handle it. Let's go.
All right. What is the most appropriate EMT level priority?
All right. So what's the most important priority? So basically, now this could be presented as, okay, put these in order of top 3 things. This could be a drag and drop question. It could be a multiple choice. They could ask it many different ways, but the concept is still going to be the same. So let's go. Give me a story.
Okay. A 19-year-old male was ejected from a vehicle.
All right. Ejected from a vehicle. That could be serious. Keep going.
Mm-hmm. He is pale, cool, and diaphoretic with altered mental
Ooh,
status.
put all that together and give me one word to describe this patient.
Shock.
Shock. All right. The fact that he's in shock, is that an oxygenation, ventilation, or a perfusion problem?
That's a perfusion
All
problem.
right. So we got a perfusion problem. He's in shock. Is he stable or unstable?
He's unstable.
Okay. So just from that one line, I know a lot of information already. Okay.
Mhm.
So I'm going to keep that in mind. He's in shock, which is a perfusion problem, and he's unstable. I probably got to do something to restore perfusion. Keep going.
His blood pressure is 88/54.
Okay. He's hypotensive,
Mhm. His heart rate is 138,
tachycardic.
and his respiratory rate is 32.
All right. We're seeing the same pattern again of increased heart rate with symptoms, increased respiratory rate with symptoms. And then he's got, now, the fact that he's hypotensive, is that going to be more of an early sign of shock or a later sign of shock?
That he's hypotensive, that's late.
All right, so he's probably in a late stage of shock. So that means it's even worse. It's even more important that you act quickly. Tell me about these radio pulses.
And radial pulses are weak.
All right, so that further confirms shock. Okay, he has
Bruising across the lower abdomen, but no major external bleeding.
Okay, so I don't see anything coming from the outside, but across his lower abdomen, he's got some bruising here. By the way, what do you call the bruising pattern that's closer to the middle, closer to the umbilicus? What's that called? What sign is that bruising pattern that's closer to the umbilicus? What's that called?
Don't remember. Cullen's.
All right, so
Cullen
that's going to be
sign.
a Cullen sign. Now, what if he has a bruising pattern closer to the flanks? What's that called?
Gray Turner.
All right, that's going to be Gray Turner. Okay, so in this case, they just say lower abdomen. So where do you think he's bleeding from? So lower abdomen is close to what body part? It could
Is
be
it the
just the
kidneys?
abdomen, but what else? What am I going to call this region?
Retroperitoneal cavity.
Okay, retroperitoneal is the word for like toward the back. They're saying the abdomen, so the abdomen is the abdominal cavity. The retroperitoneal is behind the abdomen. So this is closer to the front, but we're going to say pelvic. Okay. Now, what's so special about the pelvis is you can bleed a lot from the pelvis. Okay. And if you're bleeding a lot from the pelvis, what kind of shock could that put you in?
Hypovolemic.
All right, hypovolemic. And if you're losing blood instead of just fluid, what kind of shock do I call it?
Hemorrhagic.
That's going to be hemorrhagic shock. Okay. So we're looking for things. It's probably some kind of hemorrhagic shock. All right. So what am I going to do about it? So put this whole story together. I got a patient in shock with a perfusion problem. They're unstable and they got bleeding. So this comes down to just shock treatment. What's my first priority in shock treatment?
Control major bleeding.
We're going to control severe bleeding. Okay. Now, but that's bleeding I can see. But in this case, I don't have any major external bleeding that I can see. So what am I going to do? So what's next?
Have to get fluids.
Okay. Now, fluids is not the next thing. Fluids may be indicated, but that's not the next thing. When it comes to shock treatment, so we're going to control severe bleeding. We're going to keep this patient calm, warm, dry. We're going to maintain their oxygenation, ventilation, perfusion. Okay. We're going to check their blood glucose level. And then if we need to, we'll go with things like fluids and pressors. Okay. But there's a lot to do before I get to fluids and pressors. So jumping to fluids could cause you to miss a question because that's going too advanced too quickly. But there's a lot of basic stuff that we need to do for all shock management. So find me an answer that points to what we're going to do for this patient. Let's start with D.
B.
What about
I
D?
said
What
B.
do you think about D?
D. Wait for ALS before. No, that's delaying care.
Yep, that's going to delay care. So good. No.
Mm-hmm.
All right. What about C?
I wouldn't give oral fluids.
Why not? Because they're hypotensive. What's wrong with giving the man some water?
it's not going to get to the body
Okay. The thing is,
quick enough. But
because he's in shock, he's actually likely to be thirsty. One of the signs of shock that you're going to recognize is a patient will complain of thirst after the sympathetic activation. They'll kind of complain of thirst. However, it's so important that you know, hey, I cannot give this patient any fluids. But why? What is this patient's ultimately probably going to need trauma surgery, right? We don't want to have anything in their belly that can cause them to aspirate it up and end up choking or like getting it down into their lungs. So that's why we're not going to give anything orally in this case. What about B?
I like B.
You like B? Well, tell me about A.
Yeah. Perform a detailed secondary assessment before moving him. This is more so time sensitive, so you don't want to waste time with treatment.
Okay. He's unstable and it's time sensitive. I'm probably not even going to get to a secondary assessment. But also, when it comes to the buckets, remember how we have 5 buckets? Bucket number one. Bucket number 1 is all about the safety stuff. BSI, scene safety, mechanism of injury, number of nature of illness, number of patients, resources. That's bucket number 1. Bucket number 2 is all about the primary assessment. That's where you're going to do C-spine, general impression, level of consciousness, apparent life threats, X, A, B, C, D, E, and then transport determination. In this case, we're probably going to stay here because we got a lot to handle just in this bucket. Detailed secondary assessment comes up in bucket number 3. The reason that answer is wrong is we never do bucket number 3 stuff before we've handled bucket number 1 first and then bucket number 2. It's the wrong order. Okay, so in this case, we're only left with this. Yes, we're going to make sure we're using our C-spine precautions, treat for shock, and rapidly transport. And that's exactly what we said. We already said that he's in shock, he's unstable. We got to treat him now, and we got to do rapid transport. We already came up with that answer. Okay, let's do another one.
All right. What should you do next? This is a 2-step.
Okay. Now hold on for just a moment. So everybody in YouTube, how are we doing so far? For those of you on YouTube, Facebook, how are we doing? Let me know if you have any comments or questions. I'll try to go back and answer as many of those as I can. For the rest of you, let me know if you're having questions as well. But let's jump right back into it. So go ahead. Hold on. All right, let's go.
Okay, what should you do next? This is a 2-step.
Okay, let's go. It's all you, my man.
All right. 29-year-old pregnant patient is 30 weeks gestation and actively delivering.
Okay.
The baby's head. Oh, okay.
Keep going.
Okay. The baby's head delivers, but then retracts tightly against the perineum. Gently downward traction does not deliver the anterior shoulder. What should you do?
All right.
next?
So what do we call this? What is this pointing to? What situation is this? Okay, cool. That's the turtle sign. So think of a turtle. So you got this little head, and then you got the shell or whatever, and the head kind of comes out and then goes back in. So that's the turtle sign. What do we do for that? If your protocol allows it, what do we do for this baby?
Is it Nick Roberts?
Okay, now how do we do it? So that's the what we do. Remember, level 1 knowledge is what something is. Level 2 is what do the protocols say do about it. Level 3 is the magic, and that's the how and why. What is the Mac Roberts position? What is that?
Is it on her? Is it on her side?
Okay, so some people will say kind of knee chest, where you're putting mom on her knees, but that's not the safest thing to do in a transport environment. So the better thing to do would to have her on her back on the stretcher. But what you're going to do? So here's mom, and so here's her arms or whatever. We're going to bring her knees up. We're going to bring her knees up like this. Kind of think of these knees kind of going toward the armpits. Okay. What we're trying to do is displace the angle of the pelvis to give more room for the baby to hopefully kind of slide out. Because what's happening is the shoulder girdle is caught on the pelvic canal, and we're trying to just kind of manipulate the baby so that we can get the baby to come out easily. Now, what we're not going to do is just pull on the baby. Okay. So all we're trying to do is kind of have her change the shape of her pelvis. Everybody following what I'm doing here with my hands? So just kind of picture her pelvis moving as you bring those knees up toward so some people say knee chest, but you also want to kind of pull on the thighs and move them like upward and outward. So the way I want you to think of it is the knees are going toward the armpits. Okay. That's the McRoberts maneuver. That's part of it. The other part is you're going to have, like, while one person is kind of holding the legs or bringing the knees up toward the armpits, the other person is pushing on the pubic bone. Now, where's the pubic bone? Now, that's way down here. Okay. So that's way down here, not the fundus. So the fundus is the highest part of the uterus, and that's when do we massage that? When do we do fundal massage? Type it in the chat.
The hemorrhage, stop bleeding.
Yeah, that's going to be postpartum hemorrhaging, but this is not, in this case, in the McRoberts maneuver, we're not putting our hand at the fundus, which is the highest part. We're actually putting it down low at the pubic bone, at the symphysis pubis. Okay, so find me actually, that is the answer. So in this case, D is the answer. We're going to place this patient in McRoberts position and apply suprapubic pressure. So that's pressure above the pubic bone. Okay. And so that concept, that's turtle sign or shoulder dystocia. Okay, shoulder dystocia is where the shoulder is kind of caught on the pelvic bone. And so we're trying to manipulate the pelvic canal to make it easier, have more space for the baby to come out. All right, let's do another
one. All right, what is the best action? It was a two-step question. A 7-year-old child is found sitting upright, drooling. I'm thinking drooling. I'm thinking epiglottitis.
All right, boom. You're thinking epiglottitis. We got a pediatric patient that's drooling. Epiglottitis, sudden onset or slow onset?
Sudden.
Sudden onset. Bacterial or viral infection?
Bacteria.
Primarily bacteria. Yep. What's the number one bacteria it's going to be?
It's influenza.
Haemophilus influenza type B. Next bacteria. It's going to be Streptococcus pneumoniae, Staphylococcus aureus. Okay, so strep and staph. But Haemophilus being the number one. All right, sudden onset bacterial infection. What are we going to do for epiglottitis? Remember I teach CC'd. You've CC'd somebody on your email. We have a croupy cough and then epiglottitis drooling. Okay, in this case, drooling, epiglottitis, that matches. What are we going to do for them?
You want to keep them calm and try not to aggravate them.
All right, so find that answer.
A.
You said A?
Mm-hmm.
All right. Yeah, I would agree with that. All right, and that's what you're going to do, but you also need to be prepared for emergent intubation. So you need to, like, yes, you're going to keep this kid calm. You're going to sit, Mom, I need you to, Mom, keep the kid very calm. Use your soothing voice. Use that nice inside voice. Not, sit down, shut up, hold this baby. No, we need to keep everybody calm. Mom, what I want you to do is just hold the baby. We're going to the hospital. We're turning on our lights and sirens just as a precaution. Now, as we're saying all this, as we're doing our little speech, go ahead. I'm going ahead and I'm hooking up my blade on my innovation kit. I've already got capnography ready. The patient, we've already got the monitor leads. I'm going to go ahead and draw up my pediatric dose for my induction agent based on my protocols because I may have to intubate. I'm going to go ahead and if I have somebody else, this will be a good indication for having a rider with you. Maybe somebody else can go ahead and call in the radio report or triage or however you do it so that the hospital is prepared because this is a true life-threatening emergency. If that epiglottis closes, we lose our airway, and then the next thing may have to be a surgical airway, okay? So that's what we're gonna do for epiglottitis. Let's go back, and you wanna do another one? Here, do two more. Okay, let's go.
All right. What is the primary physiologic problem?
Okay, so this wants to know what kind of problem it is. Let's go.
All right. A 74-year-old male complains of weakness and near syncope.
Okay. Near syncope means they kind of passed out. Syncope is where there's an interruption in blood flow. So syncope is a brain problem where there's an interruption in blood flow. And if there's an interruption in blood flow, what kind of problem is that?
Perfusion.
Okay, so blood flow is probably a perfusion problem. Let's see if we can find some more evidence for a perfusion problem. Let's go.
He is pale and diaphoretic.
Oh, that's sounding like perfusion. Keep going.
His blood pressure is 78/42.
Hypotensive, okay.
His heart rate is 38.
What do you call that?
Bradycardia.
All right, so we've got,
okay,
we got bradycardia. Keep going.
Yep. And regular.
Okay.
Respiratory rate is 20 and SpO2 is 96%.
All right, tell me about this respiratory rate. Is that okay or not?
That's okay.
It's the upper limit of normal. Normal for an adult will be 12 to 20. This is at 20. So, I mean, it's at the upper limit of normal, but it's not, that by itself is not what's concerning me most. What about this pulse ox?
It's normal.
Okay, we're going to say that's normal. It falls within the 94 to 99. We're going to go with that. Tell me about the lung sounds.
They are clear.
All right, lung sounds are clear. When do we check lung sounds on which patients again?
All of them.
All patients with lungs, okay? Now, what's the main problem here? Oxygenation, ventilation, or perfusion?
This is a perfusion problem.
Find me an answer.
C.
Okay, but I knew that in the first, once, just with a few things, I knew that answer already. Without needing every bit of all the details, okay? This is primarily a perfusion problem. Now, what would I need to do to treat it? Let's say this is a multi-part question where this is the en route scene and post-scene kind of situation. Let's say the follow-up question is, what are you going to do about it? Then what are you going to do about it? So first of all, let's summarize what kind of problem this is. Sick or not sick?
He is sick.
Stable or not stable?
He is unstable.
So let's call this unstable. Is he having symptoms or not having symptoms?
He is having symptoms.
So we call that unstable, symptomatic, and is his heart rate fast or slow?
His heart rate is slow.
So that's going to be bradycardia. So unstable, symptomatic bradycardia. What's my fix for that?
Transcutaneous pacing.
Boom, just like that. And I'm in and out of that question. And I want to be thinking all of this as I'm reading the question, even though it didn't ask me, because that may be the next question. If I've already thought about it, I'm in and out of that next question. Boom, just like that. Let's go to the next one.
What is the best next action?
Okay, two-step, let's go.
A 62-year-old male has crushing chest pain, nausea, and diaphoresis.
Okay.
I'm thinking sick.
Okay, I think he's sick, so we probably need to do something. Keep going.
His BP is 92/58.
Hey, somebody calculate his MAP for us. How do we calculate the MAP again?
Systolic times. Systolic plus diastolic.
Plus twice the
times
diastolic.
2. Oh, yeah, over divided by 3.
Okay, so we're going to do 58 times 2 plus 92 divide by 3. And what do you all come up with? Somebody calculate the MAP for me. What'd you get? Okay, 69. I like that. So we have a MAP of 69. Okay, right now he's hanging on, but he's probably going to fail soon if we don't do something about it. All right, keep going.
Heart rate is 54.
Okay, so he's bradycardic. Ooh, crushing chest pain. All right, hypotensive and bradycardic. Just by that alone, what type of, even without an EKG, what type of infarct am I likely to suspect because he has bradycardia versus not having bradycardia?
Inferior.
Okay, why would you suspect that I would have an inferior involvement compared to not having that?
Because I'm thinking the right coronary artery.
Come on, my man, keep going. Let's go.
Yeah. So 85% of people get their blood flow from the right side.
Okay.
And
so that's called right dominant.
Yes.
And what are the branches off the right coronary artery?
The SA.
We have the SA nodal branch. What else?
The AV
We have
nodal
the
branch.
AV nodal branch. We also have this marginal diagonal over here. So because the SA node, which is the main pacemaker that sets the heartbeat, it gets its blood supply from the right coronary artery. If they're bradycardic, I have a high suspicion of an inferior infarct. What leads is that going to be?
Leads 2, 3 in AVF.
Okay, and it needs to be how many of those?
2.
It needs to be at least 2 contiguous leads, so 2 leads side by side in a group that go together. So you told me 2-3 AVF, and the question actually tells us that it was 2-3 AVF, so our suspicion is right, okay? Keep going. So we would say this patient is having an inferior MI. What else do I need to do when I'm doing the 12 lead if there's inferior involvement?
You need to move V4 to the right side.
I'm going to move
V4.
V4, move it to the right side of the chest, and now I'm going to run another 12 lead and call that V4R. Okay, and I'm going to write V4R on the paper. All right, he took
sildenafil 6 hours ago.
Okay, what is that? What's sildenafil?
PDE5.
Man, my man. Okay, you're showing out for real. That's a PDE5 inhibitor. No, I love it. That's a PDE5 inhibitor, and that class of drugs is what treats the condition erectile dysfunction. Okay, why did they tell us that information? Because what's special about sildenafil or any of the fils, whether it's tadalafil, vardenafil, any of the fils, what's special about them?
They cause dilation.
They cause significant vasodilation, and they're a contraindication for what medication?
Nitro.
Okay.
Nitro.
Because nitro also causes venodilation and vasodilation. So we don't want to make the vasodilation worse. So find me an answer. What are we going to do for this patient? Well, first of all, in acute coronary syndrome, what is our treatment of choice?
Avon.
Okay, let's go Avon. So what's the A?
A is aspirin.
We're going to give aspirin unless it's contraindicated. When is it? So first, when you come in the door, we say, bam, give them the aspirin. Bam. Those happen to be the contraindications. So we're going to go, bam, take this aspirin unless you have bleeding, allergies, or you've taken the max dose. Okay? So bleeding, allergies, taking the max dose, no aspirin. Otherwise, take this aspirin. All right? Then we're going to get vital signs. We're going to give oxygen if necessary, like if they're showing signs of hypoxia or respiratory distress. Or we'll give nitro unless it's contraindicated. In this case, is nitro contraindicated?
Yes.
All right, so let's get rid of the nitro. Do we need oxygen in this case?
No.
Probably not. Not yet, because he's not showing any respiratory signs. Well, he may, but right this moment, that's probably not our first choice. So even if they give us an answer choice, that's probably later down the list. Do we need vital signs?
Yes.
Yeah, because we definitely need to know the blood pressure for the nitro. But in his case, because he took a PDE5 inhibitor within the last 6 hours, that's a contraindication for it. And then aspirin, unless there's a contraindication. But aspirin would be our first drug of choice. So find me an answer.
B.
We're going to go B. Let's see. Withhold nitro, give aspirin. Okay. Yeah, I like that. So just like that, that's going to be our treatment there. All right.
I had a question.
Yes.
I had a question. So for the heart rate obviously being 54.
Hold on. Say it again.
For the heart rate, it was 54. That's just included in just the SA node, not the AV node.
Well, both, right? Because
both.
So, I mean, both of them could be affected. They're both supplied by the same artery. It just depends on how high up the blockage is. But remember, the SA node is what's the first one. So that it's this concept called overdrive suppression. Basically, it means you have a backup to keep the heart alive because we got to keep the brain alive. So when the first one, the SA node, when it goes crazy, then the backup to that is the AV node. When that fails, then the backup to that is down in the Purkinje's. Okay, so we have multiple backups. That's how God created it, so that the heart just doesn't quit. Okay, because remember, we got to keep the brain perfused. But
I have a question.
It just depends on how high up the artery, like which one of those branches got affected. or if any got affected. It depends on the blood vessel and where the blockage is. All right. Who else? Who was asking? Who said they had a?
I have a question,
right.
Maris.
Who's
what
talking?
is the national? It's Maris.
Maris. Okay. What you got?
What is the national standard for systolic blood pressure for nitro? Because in New York, it's 120 systolic.
Okay.
I know it's lower national.
I would go with 100. Some things are going to say 100. Some will say 110. Just kind of for simplicity. Like in your test question, you should be able to recognize like low versus not low, but 100 is kind of the benchmark you want to shoot for.
Okay, so they won't directly ask, a question of what the systolic blood pressure for nitroglycerin would be.
Well, I can't tell you exactly what question you're going to have on registry because nobody knows, and everybody kind of has their own adventure with the registry in terms of what questions they get and how many questions. It's less likely that you would have that type of question, but the way they would ask it is like they tell you like, okay, so in this situation, let's go back to it. In this situation, though, even if the blood pressure was 100 or 110, the fact that this patient had another contraindication, taking sildenafil, that would contraindicate nitro regardless of the blood pressure. Does that make sense?
Yeah, it's a pretty drastic difference between New York and national standards for the systolic blood pressure.
Yeah, so the number I want you to kind of commit to memory is about 100 systolic. And
okay, thank you.
And like I say, it's less likely that you're going to have that type of nitpicky question. It's the concept, though, of hypotension or other contraindications that you want to watch out for. Okay?
Thank you.
Let's say, hey, Jonathan, you want to take one?
Yes, sir.
All right, Jonathan, let's go with the next one. Hey, we're going to try to speed it up because I've got a lot more questions now. If you have to go, no problem. But I do have some more questions I want to get through if we can. So let's go.
What should you do first?
All right.
So it's going to be a two-step.
All right, let's do it.
So I'm going to read the question. You arrive first at a multi-vehicle crash with 8 patients.
Okay. Immediately, is there a safety concern potentially?
Yes.
Okay. So based on that, I'm looking for some kind of answer that deals with safety. Now, let me just show you something. As I scan these answers real quickly, I happen to see one answer says something about safety. Okay. So I might be in and out of that question already. Now, I don't want to jump the gun. I still want to carefully read, but let's just keep that in mind. All right. Now, let me speed this up just in the interest of time. We got one patient screaming. Okay. So if I have to, when it comes to the start triage and I have to assign color codes to them, the one that's screening, what color tag are they going to get?
The one that's screaming?
Yep.
Green?
They're probably going to get a green. Okay. And they've got an obvious wrist deformity. Okay. But they're screaming. That's a good sign. Now I have another one that's, keep going.
Silent, pale,
Uh-huh.
and breathing 8 times a minute.
Okay. What color am I going to give that one?
Probably a red.
It's probably going to be a red. This is probably going to be a critical. Now, based on that, this patient that's silent, pale, breathing 8 times a minute, what kind of problem do they have primarily? Do they have an oxygenation, a ventilation, or perfusion problem?
Perfusion?
Not exactly.
Oh, sorry. Ventilation.
This is primarily a ventilation problem. What would be my fix for that patient?
BVM.
Immediate BVM with high flow oxygen airway adjunct, right? Okay.
Yes, sir.
And then I have a third one with minor, who's walking around with minor bleeding. Oh, actually we may even go yellow for this one, just because they got something going on, but they're not walking. But this next one who is walking, this one, we're definitely going to have them be green. So who gets priority here?
The red patient.
Say it again.
The red patient.
The red patient gets priority. All right. So what's my answer?
It would be.
Let's start with D.
Sorry. Wait for the incident commander before touching any patient? No.
Okay. Now, we do need to have an incident commander. We do need to have somebody in control of the scene, but your job is to do patient care. So as long as the triage officer has assigned, well, in this case, you are the first person. So you're kind of the triage officer. But we still, I mean, you still need to go and assess patients very quickly. All right. What about C?
Begin transporting the first patient you can load? No.
No, because we still have to triage them according to their priority. So it's the first person may not be the most critical. We're going to transport the most critical one that we can based on the resources that we have available. All right. What about B?
Direct walking wounded to a safe area, then assess the quiet patient with abnormal breathing. I'd leave that one.
You like that one? And what about A?
Treat the wrist deformity because the patient is the loudest. No.
No, because they're less critical. So just based on elimination, we kind of eliminate it down to the right answer. But also remember, first point of the star is there a safety concern? When I scan these answers, I literally have something that has the word safe in its name. So we've got multiple ways that I probably would have gotten to that right answer there. All right, let's go to the next one. Here, I tell you what, here's what we're going to do. Let's take a 3-minute break. We're just going to take a quick 3-minute break. And when the timer will say 10 minutes, but I will be back when it counts down to 7. We'll take a quick minute break. I just need some water real quick. I'm going to go fill up my bottle and I'll come right back and we'll continue with some questions. Okay? Is that good for everybody?
Sounds good.
Okay, just 3 minutes and we'll be right back.
We're 1,000 miles from comfort. We have traveled land and sea. But as long as you are with me, there's no place I'd rather be. I would away forever, exalted in the sea. As long as I am with you, my heart continues to beat. With every step we take, Kyoto to the bay, strolling so casually. We're different and the same, gave you another name, switch up the batteries. If you gave me a chance, I would take it. It's a shot in the dark, but I'll make it. Knowing the little hope you can't shame me. When I am with you, there's no place I'd rather be. 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 We set out on a mission to find our inner peace, make it everlasting, so nothing's incomplete. It's easy being with you, sacred simplicity. As long as we're together, there's no place I'd rather be. With every step we take, Kyoto to the bay, strolling so casually. We're different and the same, gave you another name, switch up the batteries. If you gave me a chance, I would take it. It's a shot in the dark, but I'll make it. Knowing the little hope you can't shame me. When I am with you, there's no place I'd rather be. 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 When I am with you, there's no place I'd rather be.
All right. So there was a question about the start triage in terms of what do you do for the airway? Yes, you are correct that the person, especially the triage officer, remember that person's job is not to get bogged down in treatment. You're just kind of sorting through the people quickly to figure out, kind of sort them out so that the next responders can kind of go in and treat the patient. So yes, what the triage officer would do is you're going to open the airway. But what I was talking about in terms of what is the fix for the patient, it's ventilation, but it's not for the triage officer to start the actual treatment. Does that make sense? Give me whoever asked that, give me let me know if that makes sense. I think that was Amanda.
Yeah, it was Amanda. Yep, it does now.
Okay. All right, cool. And who was there? Jonathan, you ready to go back with us?
Yes, sir.
All right, let's go. So let's do another one. If you guys need to go, that's fine. We'll probably go about 30 more minutes, but if you need to go sooner, no problem. All right, let's go to the next one.
What is the most immediate priority?
Okay. So this is a two-step question. I need a story because I don't know what's the situation. So let's go.
A 45-year-old male overdosed on opioids.
Okay.
He is cyanotic with snoring respirations at 6 breaths a minute and an SpO2 of 72%.
Okay.
He has a strong carotid pulse. Your partner is preparing naloxone.
Okay. Now, so what is the immediate? So first of all, what kind of problem is this? Is this oxygenation, ventilation, or perfusion primarily?
Ventilation.
This is primarily a ventilation problem because of the respirations at 6 times a minute. Okay.
Yep.
So he's hypoventilating, and when he hypoventilates, when he doesn't breathe off enough, what does he hang on to?
CO2.
He hangs on to too much CO2. And remember from last week, we said that CO2 combines with water. That's going to ultimately form carbonic acid. And that's how the CO2 leads to acidosis. And what does acidosis do to the blood vessels?
They vasodilate.
It causes vasodilation, especially in the brain. It causes cerebral vasodilation. And that can also lead to shock in the whole body. But in the brain, it can lead to increased intracranial pressure. Okay. So what's my immediate fix for this being a ventilation problem?
It would be a BVM.
All right, we're going to go BVM. Do we use BVM by itself?
No, sir. You do it with an airway adjunct and oxygen, high flow O2.
There you go. So we're going to use a BVM to assist ventilations, but anytime we're using a BVM on anybody, we should probably consider an adjunct, and we automatically need to power it up with oxygen. Okay, so find our answer.
It would be C.
Just like that, C. Okay. Now, they could have changed this question, and see, this question was about opiate overdose. They could have made it a benzo overdose. They could have made it alcohol intoxication. They could have made it a neuromuscular disorder. I could have changed a lot of details, but it still came down to this is a ventilation problem. Okay. And the fix for that was we need to ventilate with a BVM and high flow O2 plus an airway adjunct. Let's do another one.
What is the best next action? So it'd be a two-step.
Okay.
A 52-year-old diabetic female is confused and combative.
Okay. So if I got to put those and call it something, what am I going to call that?
Altered mental status.
All right. Altered mental status. Altered mental status, does that make them sick or not sick?
Sick.
All right. Stable or unstable?
Unstable.
Okay. So I have a sick and unstable patient. Let's go.
Skin is pale, cool, and diaphoretic.
All right. Put
Blood
that together. What do I call that?
Sick and shock.
Okay. Shock. So definitely sick and unstable. Keep going. So we got shock of some kind. Keep going.
Blood pressure is 138/84.
Now, how can you have that kind of blood pressure and be in shock?
Because they're in the early stages of it.
They're in the early stages of compensated shock. Okay. That's the body's trying to do everything it can to keep itself alive. This heart rate is, we have tachycardic heart rate. Tell me about the oxygenation.
That looks good. Blood
Okay, it's
glucose.
normal. Okay.
Yes, sir.
Now, just because it's normal doesn't mean it's good. Any vital sign that's normal does not mean good. We always have to analyze the vital signs and say, does it make sense in the context of this patient right now? So keep going. Blood glucose
is 42.
All right. 42 milligrams per deciliter. How would I call that?
You would call that hypoglycemic.
All right. So we have hypoglycemic patient. How do I expect their skin to be?
Cool, pale, and diaphoretic.
Okay. And do I have that?
Yes, sir.
Okay. So that kind of supports hypoglycemia. Keep going.
She cannot follow commands and cannot safely swallow.
Okay. So that's important to know. So in this case, since this patient cannot safely swallow, if she could safely swallow, what would I have done?
Oral glucose.
Okay. Since she cannot safely swallow, then what's my next priority?
Give meds.
What kind of meds?
Glucagon or glucose.
Okay. So be a little more specific. So we're going to give, what med are we going to give in this case?
Dextrose.
Dextrose.
Okay, some kind of dextrose containing solution. And so maybe that's D10 or something like that. And how are we going to get that dextrose into their body?
Via IV.
All right, IV. And if that doesn't work, what else are we going to do? Or what else could we do? It's going to be IV or IO. Okay. And then if that doesn't work, what's our backup?
IM.
That's going to be IM. And what's the med that we would give there?
Glucagon.
IM glucagon. Okay. Give me 2 reasons for IV for glucagon. So hypoglycemia and what else?
Wouldn't it be hyperkalemia?
Which one? Type it in the chat, somebody.
Beta blocker overdose.
Beta blocker overdose. Okay. So beta blocker overdose, we would go with glucagon. Okay. So what are we going to do for this patient who cannot safely swallow? So instead of us giving oral glucose, we got to give some kind of dextrose containing solution through IV or IO. Find that answer. Well, let's start with D.
I'm sorry, I couldn't hear you.
Let's start with D. And what do you think about D?
Treat as stroke and avoid glucose administration? No.
Okay. What about C?
Withhold treatment until she becomes unresponsive? No.
No, like don't just wait until they get worse. Okay, keep going.
Provide appropriate glucose treatment per AEMT protocol. That's the one I would choose.
Okay. And in this case, they didn't specifically call it dextrose. They didn't specifically say IV. We just got to play the game with the test writer and figure out which one of these answers is the safest thing for us to do. And if we don't do it, what's going to kill this patient? This patient is hypoglycemic. Their brain is suffering. They don't have enough sugar. We got to get sugar in the body some kind of way so sugar can get into the cells. Okay. And in this case, A would be contraindicated because they can't safely swallow. All right. Now, the can't follow commands part, if they're altered, they may not be able to follow command, like they may not be fully with it because they're actually hypoglycemic. But the fact that of them not being able to safely swallow, that's what absolutely it would be a contraindication there. All right, let's do another one.
What is the best priority?
Okay.
Be a 2-step. A 71-year-old female has sudden right-sided weakness and slurred speech.
Okay. Immediately, what does your brain start thinking?
Starts thinking stroke.
All right, we start thinking of a stroke. We don't know what kind yet. We don't know if it's ischemic or hemorrhagic, but let's keep going.
Last known well was 45 minutes ago.
Okay, that would be important. Why is that important?
You'd want to report the last known well time or normal.
Why do we care though? What's so special about the last known normal time compared to when the symptoms started? It's because we've got to get this patient, if we're going to get some kind of clot busting drug like TPA or something on board, we have to beat the 4.5 hour mark, because at the 4.5 hour mark, once there's cellular damage, that's where the neutrophils show up. They bring their enzyme with it, NADPH oxidase, that causes free radical damage, and it causes more, like eventually it's going to cause more damage that's going to ultimately result in like a scar. We're trying to beat the clock before all that other stuff starts happening, and that happens around the 4.5 hour mark. So we've got to get the TPA on board like in under 3 hours, in under 4 hours if possible. That's where that window period comes from. Okay, so she's within the window period of 45 minutes, so that's good. Unless she has some other contraindication, she may be a candidate for some kind of clot busting drug. Blood pressure is
184/96.
okay.
Heart rate of 88.
Mm-hmm.
Respiratory rate of 18.
Okay.
SpO2 is 97%.
Okay, so she is hypertensive. All right, that could definitely point to especially like a hemorrhagic stroke. Blood glucose, we definitely check a blood sugar in every sign of altered mental status. Blood sugar in this case is, how would you describe it?
Normal.
Blood sugar is fine. Okay, so
it's good.
These symptoms are not due to hypoglycemia. Now, if they were due to hypoglycemia, then we would fix that first. But since the blood sugar is fine, we're going to say this is probably a stroke and not a hypoglycemic or diabetic event. What's my priority here?
For the stroke?
Yep.
You want to...
Let's start with D.
Oh, sorry. Place the patient supine and wait for symptoms to improve.
Yes or no?
No. No.
No.
Perform a stroke scale, determine last known well, and rapidly transport to an appropriate stroke center. That sounds pretty good.
Okay. What about B?
Lower the blood pressure before transport? No.
No. Okay. And because that pressure may be the only thing keeping them alive. If we drop it too quickly, we may actually stop the perfusion to the brain. Keep going. And what about A?
Give oral glucose because stroke mimics are common. They're not hypoglycemic.
They're not hypoglycemic. There's no indication for that. So this is a time-sensitive situation where we're going to get this patient right to a stroke center. And we need to go ahead and immediately call a stroke alert. And from the time that we arrive at the hospital, we want to be at the CT within 10 minutes. The sooner, the better. Ideally, we don't want to stop in the ER at all. We want to go from the ambulance bay directly to the CT scanner. Okay. Here, I tell you what, I'm going to skip ahead just a little bit. Here, let's do this one.
What is the best EMT level action?
Okay.
2-step.
All right, let's go.
I mean, I don't know what they'd be doing. 2-year-old has a barking cough,
okay.
low-grade fever.
When do I think of that? What condition do I think of this?
CCED.
Okay, and what's that? Like what condition would have the cough?
That'd be like a...
So one condition has drooling, one condition has a cough. Which is the one with the cough?
Croup.
That's going to be croup, also known as
laryngotracheobronchitis.
Laryngotracheobronchiolitis. Okay, cool. I like it. And viral or bacterial infection?
Viral.
Primarily viral. Sudden onset or gradual onset?
Gradual.
Primarily gradual onset. What's the number one virus? It's going to be parainfluenza virus, or often it can be respiratory syncytial virus, okay, or other viral infections, but these are probably the most common, okay? What am I going to do for this croupy patient?
Give them oxygen.
Okay, now we may give humidified oxygen or take them outside in the cool, moist environment. The biggest thing is to keep this patient as calm as possible, though. So in this case, we're actually just going to go with A. Now, one thing, especially at the paramedic level, based on your protocols, one additional thing that you may do is we may end up having to give this patient some kind of steroid like dexamethasone, so Decadron or something like that. Okay, that's what we're going to do for this one. All right, so Maris, you ready to come in?
Sure, I'll give it a shot.
Okay, let's go. Let me find you. All right, hold on. Let's find Maris. Let's bring her in. Everybody still learning something tonight? Okay,
Yeah.
so Maris, it's all you.
I can't see it. I just see Jalen right now. Hold on.
Okay, does everybody else see my screen?
Okay, I can see it now.
Okay.
What is the most appropriate AEMT level treatment priority?
Okay.
It's a 2-step.
All right. Oh, this is a good one.
A 33-year-old male has vomiting and diarrhea for 2 days.
All right, stop right there. Vomiting for 2 days. What kind of what kind of acid-base problem could that lead to?
Metabolic alkalosis.
Okay, you're saying metabolic, which one?
Alkalosis.
Alkalosis. Okay, all right. And what about diarrhea for 2 days?
Metabolic acidosis.
Metabolic acidosis. Okay. And the way we remember that is which end is it coming out of? The diarrhea comes out of and then that's called acidosis. Okay, cool. All right, what else? Now, both of these, vomiting and diarrhea, can lead to what ultimately? Both of those are fluids, and when we lose too much fluids, that can lead to what?
Hypovolemic shock.
Hypovolemic shock. Is that going to be a oxygenation, ventilation, or perfusion problem?
Perfusion.
It's going to be a perfusion problem. So our treatment is aimed at restoring perfusion. So this was vomiting and diarrhea, but it's still a perfusion problem. All right, keep going.
He's weak and dizzy when standing.
Okay, that's not good. Okay, so
His
weak and
orthostatics
dizzy
are off.
with standing, that also could support some kind of orthostatic hypotension, where when he stands up, we don't have enough blood flow going to the brain. Okay, his pressure he is hypotensive, he is tachycardic, respiratory rate he is slightly tachypneic. What about his
Elevated.
oxygenation?
Normal.
Okay, tell me about his skin.
Cool.
Okay,
And lungs are clear.
Lungs
so
are
I'd say
clear.
he's
That's
kind of
good.
shocky.
so this patient is some kind of shock situation. And so based on that, find me an answer that would make sense.
So start with D, place him supine and delay IV access until arrival. No, because you don't want to delay, and that's not addressing the perfusion problem.
Okay.
Restrict fluids because all shock patients may develop pulmonary edema. That's also incorrect.
No, now it can happen, and so that's why I need to be checking, I need to be checking breath sounds before and after fluids, but I don't base my decision to do breath sounds on fluids. I base my decision for breath sounds on if it's a patient with lungs, right?
Yeah, and here it states the patient's lungs are clear.
Okay.
Nitroglycerin for possible cardiac weakness. There's nothing that really indicates that, and his blood pressure is
with his
not
blood pressure, that would definitely
sufficient.
be contraindicated. So I'm only left with an IV crystalloid fluid bolus. What would be my fluid of choice in this situation?
I would do lactated ringers because he's borderline acidotic to start with.
It could be. Now, if in this case for straight hypovolemia, normal saline may be fine. It's just based on what you have available and based on your protocols. But we want some kind of isotonic crystalloid like ringers or saline. If I can use ringers, I may go with that, but saline would also be fine here for just strict hypovolemia. All right, let's go to the next one. Oh, wait, hold on. Let me see what else. Okay, yeah, we'll go to the next one.
What is the best treatment priority? So it's a 2-step question.
Okay.
A 40-year-old male found in a garage with a running generator.
All right, so what am I thinking is the problem?
CO poisoning or some kind of toxin.
Okay.
Safety
Carbon
issue.
monoxide poisoning is what kind of problem? Oxygenation, ventilation, or perfusion primarily?
I'm going to go with ventilation.
Okay. So the main problem here is it's an oxygenation problem, because on this red blood cell, so here's our hemoglobin, and what's supposed to be connected to the hemoglobin is oxygen. However, in carbon monoxide poisoning, the carbon monoxide loves to hang out with the hemoglobin, and so we've got carbon monoxide attached in all the spots. So we may have 100% sat, but it's saturated with the wrong stuff that could still kill this patient. So this is an oxygenation problem where oxygen doesn't get into the tissues. So this is primarily an oxygenation problem. And how do I fix oxygenation problems?
With oxygen or airway.
Okay, I either do something to the airway to open it up to get more air in, or I give them oxygen to give more oxygen. Okay, find me an answer based on that. Let's start with D.
I would go with B, but start with D is treat as anxiety and allow them to remain in place. No. Give naloxone for presumed opiate overdose. There's nothing that indicates that as far as his presentation and
what would I be looking for a presumed opiate overdose?
Ventilation issue and pinpoint pupils.
Okay, I'm looking for, yep, and I don't have either one of those. In fact, you said that's primarily a ventilation problem, and CO2 or carbon monoxide is primarily an oxygenation problem. There, okay, I like that.
Administer high flow oxygen, remove all patients from exposure. I would say yes.
Okay.
And reassure the family because the pulse oximeter is normal. I would definitely say no.
His sats are fine. He's just got a little carbon monoxide poisoning. He's gonna be all right. What do we really need to displace all of that carbon monoxide from being bound to the hemoglobin? What does this patient ultimately need?
Hyperbaric.
Hyperbaric oxygen. Okay. So that's going to be pressurized oxygen. They're going to put them in the iron lung so that it can hopefully displace some of that hemoglobin over time. All right. So they need high flow O2. Specifically, they need hyperbaric oxygen. Let's keep going.
What should you suspect and how should you manage her? It's a two-step question.
Okay.
A 34-week pregnant patient has painless, bright red vaginal bleeding. So right away, I'm thinking placenta previa.
Okay, we're thinking placenta previa. Is that what you're thinking? Find me an answer.
I would say B. However, now I'm second guessing it because she's 34 weeks.
Okay. So when does placenta previa typically occur?
I thought it was sometime in the second trimester.
It's typically a later term. She's in her third trimester. That can very well happen.
Okay, I thought it was earlier. Maybe it's not. I mean, I know like painless would be previa, so I'm kind of like that's what I was thinking.
And so that's kind of the main way we want to approach this one. So in this situation, would we expect it to be a ruptured ectopic at 34 weeks?
No.
Okay, so I'm going to probably eliminate an ectopic pregnancy because I expect that to happen in the first term. Okay, now the fact that she's having, now I don't really worry about the color, bright red, dark red. I don't really care about that. I'm looking for things like painless or painful vaginal bleeding. Now I would probably need to if I keep reading this, I'm going to get another clue that's probably going to support placenta previa. And that clue is going to be, okay, this has happened once before during her pregnancy. So she could have had some bleeding recently. Like she could have had more bleeding earlier. But in this case, I'm probably thinking more of the fact that it's painless. I'm kind of leaning more toward placenta previa versus an abruption. And in that case, I'm probably going to go with that, and I'm going to answer the question based on that. Because even if I read the rest of it, I mean, I'm still going to probably get to the same answer. So,
yeah.
All right. Now, what would make it more likely to be an abruption?
It's usually painful.
Okay. Typically, painful bleeding. Both of them can be vaginal bleeding. And I'm not worried about the color because the color can change as the blood gets oxidized, as clots form, stuff like that. Okay. That's how I would approach that question. Let's go to another one.
What is the best next priority? Is it two-step?
Okay.
ROSC is achieved after 2 shocks and high quality CPR.
Do we pack up, go home, and say they made it?
No.
No, because they may be back in cardiac arrest in a moment if we don't do something. Keep going.
The patient is unconscious with a pulse.
Okay, they do have a pulse, so they're no longer in cardiac arrest, but they are unconscious. Blood pressure?
Is 88 over 54.
Okay, this patient's hypotensive. Okay.
Hypotensive. Heart rate of 118 is tachycardic.
Okay.
And respirations are assisted by BVM.
Okay, how often should we be ventilating this patient who was just in cardiac arrest?
1 breath every 5 to 6 seconds.
Okay, 1 breath every 5 to 6 seconds for an adult, 1 breath every 2 to 3 seconds for a kid. Our oxygenation seems to be okay. Tell me about the end tidal.
Is normal.
Okay, it's normal, which is what we expect to tell us that we have ROSC. Now, is our what's our end tidal probably going to be while they're in cardiac arrest if we're doing high quality CPR?
Somewhere around like 12.
12, 17, 18, something like that, okay? Now, if our end tidal starts to drop, what does that probably tell us?
Like fatigue from the
rescue
compressor.
Fatigue. We're not doing compressions well enough. And if we get a sudden rise, what does that tell us? Like a sudden rise back to normal.
ROSC.
We probably have ROSC. We probably have a perfusing heartbeat. So in this case, we achieved ROSC. What's our next priority?
So D, delay transport until the patient wakes up. Well, that's not true.
Okay.
You don't want to delay, and it could be months, days before the patient wakes up.
Okay.
Begin post-ROSC care, optimize oxygenation, ventilation, support blood pressure, obtain 12 lead and transport appropriate facility. I would say that's definitely an answer.
Right. Let's just get in and out of that question. We got it. Hold on. Let me find. Oh, this. Yeah, let's do this one.
Okay. What is the most appropriate next action? It's a 2-step.
Okay.
You respond for a 64-year-old male with shortness of breath.
All right, so we got shortness of breath.
64.
Okay.
I would say 64. You could have a bunch of possible comorbidities.
Okay.
He's sitting upright, speaking Woodward sentences, so he's still fighting. He's still getting words out. It's more of an oxygenation problem.
Okay, could be.
Appears exhausted. Okay, so he's fatigued, so maybe more towards ventilation issue.
Okay.
His skin is pale and diaphoretic. He's definitely shocky.
Okay.
Vitals are 158 over 92, so he's hypertensive. Heart rate of 128, tachycardic, and respiratory rate of 8 and shallow. So he's definitely in ventilation.
All right, we got a ventilation problem. We got enough evidence to support ventilation problem. Fine. What's my fix?
I would say B.
Assist ventilations with that even has ventilations in its name, and that's going to be with a BVM high flow O2. Now, in this case, the reason a non-rebreather, the reason A is wrong here is this is more of a ventilation problem now with respiratory failure instead of respiratory distress. The fact that this patient is now exhausted and has shallow breathing for sure is respiratory failure. That's a ventilation instead of an oxygenation problem. A is wrong because it fixes an oxygenation issue and not a ventilation issue. Okay? Let's do another one. Let me find here. Let me just there was one I want. Oh, this one. Let's go to this one.
What is the most appropriate treatment priority?
Okay.
It's a 2-step.
All right, and everybody, make sure you're following along. Everybody.
A 72-year-old female reports weakness and dizziness.
Okay. So kind of non-specific. I mean, the dizziness I'm a little concerned with. That could be neurological. It could be an infection. It could be a lot of different things for weakness and dizziness, but keep going.
She has had black tarry stool for 3 days.
Ooh,
so I'd say
now that's
lower
something.
GI bleed.
Okay, keep going. What were you saying about that?
Lower GI bleed is suspected.
Now, is it lower GI? What is that called? What is the word for this? This whole black, say it again.
Melena.
Okay. So we suspect that this patient has melena, and what kind of situation is that? In fact, let's do that. Let's change my colors there to kind of match what it really looks like. So we're going to say kind of black tarry stools. What kind of bleed is that? Why is it tarry? So this is actually more of an upper GI bleed. And you say, well, wait a minute, it's the stool, so how is it upper? Well, the bleeding is upper. It's just that that blood is getting digested and it's coming out the other end. But the reason the color is dark is because it's digested blood versus fresh blood. Okay. Now,
Okay.
what is the one where you have like bright red blood coming out the rectum? Anybody? Type it in the chat. All right, so that's going to be hematochezia. And hematochezia is going to be primarily bright red blood from an upper GI bleed. Okay, so both of them are coming out the butt. It's just, where did it start from? So in Melina, we have an upper GI bleed, and the reason it's dark is because it's digested blood. So let's just add that in. That's going to be digested blood. So this probably started at the esophagus. It probably started maybe in the stomach. It could have been esophageal varices. It could have been like a ruptured esophagus from a lot of vomiting. So Boerhaave syndrome, something like that. Or in the case of hematochezia, that's going to be wait, hold on. No, I did this wrong. This is not upper, that's lower. Hematochezia, that's going to be bright red or fresh blood from a lower GI bleed. So that's going to be more like the colon, the sigmoid, much lower down, or it could be hemorrhoids close to the rectum. All right. So in this case, but either way, I still got a bleed. Wherever it's coming from, it's still a bleed. And when I'm losing blood, what kind of shock could that put me in?
Hypovolemic or hemorrhagic?
Hypovolemic, specifically hemorrhagic shock. Okay. So, and shock is what kind of problem? Oxygenation, ventilation, or perfusion?
Perfusion.
All right. So I got to do something to restore this perfusion. Find me an answer. Let's start with D.
So D, give oral fluids to replace volume before transport? No.
No, because if they got a bleed, they're probably going to need surgery. And if I give them oral fluids prior to surgery, that can cause them to aspirate. That's why it's wrong. Keep going.
Administer nitroglycerin for suspected cardiac-related weakness. There's nothing in there about that, and his blood pressure doesn't support it.
Correct. And yeah, this blood pressure definitely doesn't support it, but it just wouldn't be indicated. All right, keep going.
Place her in a seated position and delay transport until a stool sample is obtained. We're not going to sit there and wait for her to poop, and we don't want to delay transport.
Hey, and smear, give me a little poop to smear on this card. Keep going.
That's outside my scope.
Right. Okay, so we're going to go with A, administer high flow oxygen. Now, that's if it's needed. Establish IV access. We're probably going to have to give some kind of fluids to get this pressure up, okay? Because what's our map in this situation? All right, so we're going to do 48 times 2 plus 84. So what's our map? Divide by 3. So we get 60, right?
60.
Okay, so is this map good or not?
Not good.
This map is definitely not good. What is our target map that we need?
Map is 65.
We need at least 65. So we're going to give fluids until we get a systolic pressure greater than 90 or a map greater than 65. If we give fluids and we're not able to get the map up, then what are we going to do?
You're going to probably go with Levofed?
We're probably going to have to go with some kind of pressure, yeah, based on your protocols. Okay, let's do another one. Ooh,
what is the
cool
best EMT level priority? Okay.
Okay, keep going.
Oh, I thought you said stop here. Okay.
Oh, no. I mean, this may be the last question, but you keep going.
Okay, I'm sorry. What is the best EMT level priority? It's a 2-step.
Okay.
A 21-year-old male fell from a roof.
Okay, so right now I know trauma.
Yep. He opens his eyes to pain, makes incomprehensible sounds, and withdrawals from painful stimulus.
All right, stop right there. Let's figure out this guy's GCS. So what is his GCS? Remember, we got 3 categories. What are they?
Eyes, motor, voice and motor.
Okay, eyes, verbal, motor. What's
Verbal
the highest
motor.
for eyes?
4.
Okay, highest for verbal?
5.
Motor?
6.
Okay, let's figure out his GCS. So under eyes, what does he get? Because it's going to be
He opens his eyes to pain.
Okay.
So 2.
That's going to be a 2. So we got a 2 for eyes. What about verbal?
Incomprehensible sounds. So he's going to be a 1.
1 is
1 or
none.
2. Okay, so 2.
He's going to be a 2 there. Okay. And then what about for motor?
Withdrawals from painful. I would say he's a
Say it.
4.
He's a 4. Okay, cool. So add that up. And what's his GCS?
8.
He's got a GCS of 8. Okay. What is our normal GCS? What's the highest and what's the lowest?
The lowest is 3, highest is 15.
Okay. So a normal would be 15. He's at 8. Okay. He's significantly altered. Now keep going though.
He has slow, irregular respirations.
Ooh.
So I'm thinking ventilation.
I like it. Slow, irregular respirations. Okay. Keep going.
A large scalp hematoma.
Okay. That large hematoma can further contribute to more blood loss. But what else does it tell me? The fact that he has a scalp hematoma, what else is happening inside of his head?
It sounds like Cushing's triad for me, but
okay, you want to go with Cushing's triad because of what?
Well, he's got irregular respirations. He's got reflex bradycardia, and he's hypertensive.
Ah, okay. So Cushing's triad seems like a plausible situation. So we've got increased intracranial pressure there. And what are we going to do for it? Let's start with D.
So D, delay transport until a full neurological assessment is completed. No, we're not delaying transport.
No.
Place the patient in Trendelenburg position to increase cerebral perfusion. No.
No, because that's actually going to increase the amount of blood going to his head and make that intracranial hemorrhage, that brain bleed, even worse. Okay, let's keep going.
I would go with B, assist ventilations with high flow oxygen.
If you would go with B, let's just go with B. Because you already told me it was we had he had slow respirations. You already told me he had a ventilation problem. This actually talks about ventilations. So we're going to assist ventilations with the BVM. And we actually don't want to just routinely hyperventilate these patients. Why is that though? Why do we not routinely hyperventilate these head injury patients? That's kind of an old way of thinking.
Increasing the ICP.
Say it again.
You're going to increase the ICP.
Okay. Because when we hyperventilate, we blow off some of the CO2, but what that can actually do is it can actually cause given all that oxygen can cause vasoconstriction. Yeah. And that actually slows. I mean, yes, that seems like a good thing. And that's where it came from. But you're actually shunting blood in the head. So you're decreasing the amount of blood that the brain has to perfuse. So that's why it can actually be very dangerous. Okay. All right. Any questions about today? How was tonight's session?
I thought it was great, but I don't know. I feel like the test is so different, but I feel great about it.
Okay. Well, the test is very similar to what we did. It's just we don't have, we don't know for sure what kind of questions you're going to have or what exact questions you're going to have, but it's all coming from just content from the domains. We got to get everything down to, we're going to use the 5-star medic method, and then we're going to get everything down to as much as possible. Is this oxygenation, ventilation, or perfusion? When I know that, I'm now much more prepared to answer almost any question they give me. Now, sometimes they're going to ask just random off-the-wall kind of questions where it's just some random content or some random concept. It could just be some some luck of the draw, or that test writer just happens to love this question. Some of those kind of bizarre questions or pilot questions that are not scored, they're not a part of your overall score anyway. They're just questions to see if that question is going to later end up in the test bank. Okay, so what I want you guys to do is continue doing it exactly like we did tonight. And I promise you that if you'll follow this method, you're going to get the correct answer more often than not. Remember, you don't have to know everything to pass the test. You just have to make enough safe decisions to pass the test. Okay? I hope this was beneficial for everybody tonight. Any final questions? Now, for those of you who joined us tonight who are not a part of our community, I would invite you to consider doing this. The people that you heard from tonight, they are actually, all of them are a part of our community. So all of them are a part of either the NREMT Pass Study course and or the 14 Days to Paramedic Immersion experience. I would invite you to join that as well, regardless of your level, especially if you're at the advanced EMT level or the paramedic level. That kind of structured support is going to help you a lot. It has helped a lot of people pass. You can just go to levelupmedic.com, go under NREMT, the part where it says NREMT, and based on your level, it'll route you to the different page to sign up for either the NREMT Pass Study course or the 14 Days to Paramedic Immersion experience. Once again, I am your host, Coach Joshua. It was a pleasure being with everybody. Does anybody have any final questions for me? On YouTube, on Zoom, Facebook, wherever you are, does anybody have any questions? Just type it in the chat for me.
I have a question.
Okay, who's talking?
Jalen.
Jalen, okay. What you got?
So I'm on the last week of the challenge, and one of the, I guess it's the 7 days before exam, it says, consider doing coach's practice test number 1, diagnostic assessment. Where do I find that?
Okay, that's something, if you'll just send me a message inside of school, I will send that to you.
Okay.
Okay. Yes, just send me a message in school and I'll email that over to you.
Okay.
Okay, and then you'll need to just let me know that you've done it, and then I'll score it. And hopefully, I mean, we've been working on this for 2 weeks now, but very, very soon, all of the testing stuff is going to be electronic, where everybody will have access to it based on your level. You'll have access to different tests. As of today, you'll just ask me for it in school. Going forward, for those of you who are coming behind pretty soon, that's actually going to be on a new testing platform that we'll be releasing very, very soon. Okay, any other questions? Any other questions from anybody?
I have probably one more.
Yes, go for it.
So I know you said when the first question we had when we were doing the body surface area for burns, I did not know that we don't count superficial burns.
Yeah, because we're not typically, like for a sunburn or something like that, we're not typically doing aggressive fluid resuscitation. We're just going to stop the burning process. That's first line for all burns, is to stop the burning. And then we're going to bring them into a cool area. We may end up using some kind of like aloe vera gel or something like that. You want to be very careful with burn creams, especially if they have any kind of partial thickness or full thickness burns, because even though it's marketed for burns, it can cause a lot of pain, and it can also damage the tissue when we have to remove it, especially at the hospital when we have to do the debridement to remove that. Imagine all the friction that you have to, all the rubbing that it takes to clear all that cream off. That can actually cause more tissue necrosis, and it can cause a lot of pain. So we don't need to be doing any kind of burn creams. But yes, to answer your question, it's primarily targeted to partial thickness and full thickness burns.
Okay.
Okay. Anything else? All right. Well, guys, this was a pleasure. I hope you learned something tonight. And for those of you who are inside, make sure that you're just continuing to follow the 21-day game plan. If you have any questions, don't hesitate to reach out. For those of you who joined us tonight, I hope you learned something. Put a comment to let us know what you learned. And if you would like the same kind of help that these students are getting, I invite you to join us, and we'll see you inside. That's it for me, everybody. We will end it now. Have a great night. Talk to you soon.
Thanks, Coach.
You are certainly welcome.